All right, hey everybody. Um, so I am Dr. Marshall Ash. I'm a child and adolescent and adult psychiatrist at Peak Vista Community Health Centers here in Colorado Springs. And today we're going to talk about integrating psychiatry at Peak Vista. And please feel free to interrupt at any time. Want this to be people, yeah, feel free to interrupt, ask questions, make it conversational. All right. Um,
Oh, Dagger. It looks like we can't see your slides yet.
oh no.
I think they might have gotten closed out.
Oh, let's see. See. There we go. Can you see it now?
Yes. Yeah, those look great.
All right, very good. So like I said, I'm Dr. Ash. I went to medical school at Rocky Vista University, College of Osteopathic Medicine in Parker. I then went out to Dayton, Ohio, Wright State University to complete my general psychiatry residency and completed a child and adolescent psychiatry fellowship as well. After completing training, I moved back to Colorado because it's hard to live anywhere else after living out here, and joined Peak Vista Community Health Centers. And here I serve as the director of the psychiatric service line and the medical director of the Developmental Disabilities Health Center. So today we're going to talk about a current problem in psychiatry across the US and some current approaches that are being utilized to try to address that problem. We are going to talk about integrated psychiatry at Peak Vista, the program logistics. We're going to go through a couple of sample scenarios and then talk about the impact that we have seen so far here at this model. So first, the current problem and current approaches. We know that roughly 1 in 5 adults in the US will experience a mental health condition each year, and roughly 1 in 10 children will have mental health symptoms that contribute to dysfunction each year. And that there's a significant shortage of psychiatric providers in the United States. My team often hears me say that we will never be able to out-hire the shortage. Some studies have been done. One is from 2018. They estimated that the country is going to have a shortage of 14,000 to 31,000 psychiatrists by 2024. So that was 2 years ago. And also, mind you, this is a study on psychiatrists alone, not even including psychiatric nurse practitioners and PAs. There was another study of psychiatrists that found of those surveyed, only 18.5% were accepting new patients. For those who were accepting new patients, there was an average wait time of 67 days to be able to get a new appointment. Um, so if you practically think about patients in your clinics, the ones that you're taking care of, by the time they ask for a referral to psychiatry or come to a primary care appointment to get help with their mental health, they've already been waiting a long time. And if you send out a referral, only 18.5% of the psychiatrists are accepting new patients. That's not a great success rate for finding a good referral destination. And then even if they do get accepted, they're going to have to wait at least another 2 months often, and sometimes longer, to get in to see psychiatry. Here at Peak Vista, our primary care providers are the primary managers of psychiatric medications, largely because of the shortage across the country. They also have to deal with shorter appointment times than we have in psychiatry, with limited support to complete the job, and oftentimes with limited comfort in managing highly complex psychiatric concerns. Our primary care providers are great. They do a wonderful job. And yet I know that they wouldn't want to be managing the most complex cardiac diseases. They would be sending them to cardiologists. They won't want to be managing highly complex type 1 diabetes with multiple other comorbidities. They're going to lean on their endocrinology team. And same with mental health. So then that leaves Peak Vista's patients with limited external referral success and then caught in limbo with advancing severity of symptoms and nowhere to turn for help. There are two current models. There's many models, but two of the current models on integration or of integration that are being utilized to try to address the problem are primary care behavioral health and the collaborative care model. For those of you not familiar with it, primary care behavioral health is the embedding of behavioral health providers into primary care clinics to provide real-time immediate behavioral health interventions, often providing health behavior counseling, There is no formal referral required for behavioral health providers to intervene. And there's minimal disruption to primary care provider workflows when having a behavioral health provider in-house. Here at Peak Vista, they do a lot of co-visits where the behavioral health provider can come in before or after the primary care provider so that the PCP can continue seeing the patients that they need to see that day. But some of the drawbacks of this model of integration is that there's still a higher level of psychiatric consultation needing external referrals. These behavioral health providers are not prescribers. They have a limited scope, so they have limited ability to provide medical recommendations. Another model of integration is the collaborative care model. This was largely created out of the University of Washington, their Ames Center. And it's a model where there is a registry of patients that is being managed by a behavioral health case manager, often a nurse case manager or another skilled provider, where they manage a panel of patients, 50 to 100 patients, depending on intensity. And they have a regular recurring consultation time with a psychiatry provider, a PMHNP or psychiatrist or PA, to review that panel of patients, look at their measurement-based scores like PHQ-9s, depression screenings and anxiety screenings, and see who needs higher levels of care or where the primary care providers might need some support in managing their symptoms. The benefit is that the availability of psychiatric providers to support the primary care providers actually amplifies the number of patients that can be impacted. Instead of the psychiatry provider having to see every single patient, they can support the PCPs in the work that they are doing. It's an improvement in resource management, and the use of a registry does help limit patients from falling through the cracks. If someone doesn't make it to their follow-up appointment, there's active tracking from an active case manager who's able to look through and follow up with that patient directly. Some of the drawbacks, though, to this model are that the psychiatric provider is rarely on site, which limits the ease of direct access. So they might have a setup where they're reviewing the patient panel, the caseload once every 2 weeks or once a month. Direct consultation often still does require a referral, and often to an external location or an external system if that psychiatric provider is only contracting in to provide that consultation. And some models of collaborative care model do limit ability to be on that registry. They limit it to certain specific diagnoses. For example, you can be on the part of this program if you have major depressive disorder, but you're excluded if you have bipolar disorder or schizophrenia. And so integrated psychiatry at Peak Vista, knowing that there are these two models available, we decided that we wanted to braid these approaches. We wanted to provide faster access to the appropriate level of care. We wanted to provide more support, psychiatric support, to primary care providers and behavioral health providers. We want to reduce barriers to collaboration, amplify the impact of every single psychiatric provider, again, knowing that there's a shortage we can never out-hire, and provide education to primary care providers so that they can have an even greater impact to their patients. We want to avoid adding workload to the primary care team. We want to avoid simply being co-located and having our own panel of patients that we're seeing just side by side and no availability then to collaborate with the primary care providers because now everyone is overscheduled. We want to avoid duplicating services, specifically avoiding duplicating the services that the behavioral health providers are already providing and doing a great job at. We want to avoid the behavioral health providers becoming gatekeepers to psychiatry because that is not their role. And we want to avoid unnecessary overutilization of specialty mental health care clinics. Because we know there's a shortage, we want to utilize those services appropriately. And so we really want to emphasize that the most complex patients should be the ones who are on the schedule for the psychiatric providers. So Peak Vista was so willing to allow us to begin integrated psychiatry at Peak Vista. This program places a psychiatric provider directly inside a primary care clinic, not in a separate building, not on a referral list, but right there as part of the primary care team. Peak Vista has roughly 21 primary care clinics across Colorado Springs and the surrounding area, and we decided to pilot this program at the health center at Jetwing. We chose this site because it's a multi-specialty primary care clinic with family medicine providers, pediatricians, behavioral health providers, and a full dental team. This is a team that was also very open to innovation. They saw the potential benefit to having psychiatry in-house with them, and they were always willing to try something new for their patients and for themselves so they could learn. And because there were so many providers at this clinic, we knew that there would for sure be a high enough volume of patients that would support having a full-time psychiatric provider in-house. At the time that we started, there were 6 primary care providers, a mix of behavioral health and pediatrics, each averaging 20 to 24 patients a day. And so there's a lot of patients coming through. As we set up the program of integrated psychiatry, we've been centering ourselves on this mission that we at Peak Vista seek to improve access to mental health care for Peak Vista patients through innovative psychiatric clinical programming. And with our vision, we aim to do this through amplifying the impact of each psychiatric provider. We aim to reduce stigma associated with receiving psychiatric care. We aim to improve patient and provider satisfaction when interacting with our mental health care system. And we aim to demonstrate a sustainable model of care. So what we do is in the integrated psychiatry program is we have 3 pillars or 3 different areas that we are primarily providing a service. First is direct patient care. We do still have scheduled appointments where we see patients face to face. We take on new patients, we continue their medication management, and then when we are able to, we transfer them back to primary care. We also offer indirect consultations. Simplistically, this is like a curbside consult, but it's formalized. Knowing that we have team-based approaches in many of our clinics, we know that patients will not necessarily see the same primary care provider over and over again. So instead of having the hallway conversation with a provider, we have that conversation and we document that conversation as well, so that the primary care provider who sees them at the next appointment can see the recommendation that we had provided. This all happens without a formal patient visit. The patient does need to verbally consent, and that needs to be documented by the primary care provider. The primary care provider has to initiate that consult request, but these consultations do not involve me seeing a single patient. We also provide education for primary care providers. We provide ongoing education largely during our monthly provider meetings, where we carve out a portion of that time where we, during some of our downtime, if we have patients that are not showing up for an appointment, we'll use that time to create 1-page handouts to give to primary care providers on the nuts and bolts of managing ADHD in adults, the nuts and bolts of managing mood stabilizers and how to continue monitoring for metabolic syndrome and other medication level monitoring. So we hand out we give these handouts to the primary care providers. And then again, providing that daily education, reminders and support for them real time. Because we know that better informed primary care providers means better care for everyone. What this means for our patients is that they have mental health support in the same building and many times at the same time as their primary care appointment. This is where we attempt to reduce stigma. So if you are coming in to see your primary care provider and you now need to see a mental health provider, a prescriber, it can reduce a barrier and reduce stigma if I can just go to my primary care clinic to see a psychiatry provider. Instead of being concerned about, well, if I go to this clinic and now someone drives past and sees my car in the parking lot at the psychiatry office, what are they going to think? And it also helps to socialize people to mental health being a normal part of everyday health. And that's a part of care here at Peak Vista. This means that the patients are working with a trusted provider because the psychiatry provider is an extension of the care team that the patient already knows. There's faster access to psychiatric care because there's no long referral wait times. We attempt at all opportunities to allow for warm handoffs, for same clinic and same day scheduling whenever possible. And again, this is emphasizing whole person care, that mental and physical health are treated as one because they are. So logistically, what does this look like? How did we set up this program, and how do we make this flow? So like I said in a previous slide, the integrated psychiatry provider is embedded within a primary care clinic. They are a captive consultant to those primary care providers. From a logistical scheduling perspective, they have part of their time as scheduled appointments, meaning intake appointments and follow-up appointments. And there's also protected consultation time. That is time that we are not to schedule patients It is not admin time. It is not lunch time. It is consultation time. We intentionally protect this time so that these providers are not so overscheduled that no one wants to approach them and ask them for help because they see how busy they are. I'm sure you all have been in clinics or in other work settings where you see someone like hammering away at their keyboard and running between exam rooms and like, whoa, they're super busy. I don't want to interrupt their day. We don't want to have that, and we actively fight against that by having this protected time. During this consultation time, we're available for those indirect consults. We're available for same-day problem-focused consults. We're going to review what those look like, as well as comprehensive consults where we see a same-day walk-in. We do a full intake. We have that time protected so that we can help our primary care colleagues provide care for their patients. Even if someone comes in and a primary care provider needs help, even outside of this protected consultation time, we are interruptible. Instead of a traditional outpatient psychiatry clinic, where once that door closes, it doesn't open and no one talks to you until after the appointment is done, here our patients know that we're interruptible and that if we take time away from their appointment, we're going to give that back to them because we have some flexibility and margin in our day to shift schedules. Our goal is that we have same-day consultations, again, varying levels of intensity, that we never have more than a 4-week wait for a new face-to-face appointment. And I'll tell you, most of the time that's limited by a patient's availability to not be able to stay for another hour-long appointment that day, not necessarily because of the psychiatry provider's schedule. And then we also aim to be a revolving door and not long-term care. Our goal is to support patients when they're in a time of need, to find a place of stability for them, where we can then transfer their care back to primary care for ongoing management, refills, and that then reopens our schedule to see more patients. For staffing, we run lean. We have a 1-to-1 psychiatry provider to medical assistant ratio, and we utilize the already existing support staff and operational administrative supports in-house. We do not ask for additional front desk staff, for additional referral navigator staff, for additional operations staff. We utilize the services already there. Those of us in the program manage our own scheduling as well. We do this intentionally so that we can help to triage and make sure that those who are most complex get onto our schedule, and those who maybe just have a couple of questions that we can answer without having to have a full hour-long intake, we can answer that with their primary care provider without having to take up their time and ask them to come in for a full appointment. From an infrastructure perspective, we have a very minimal square footage requirement. Literally, it's what rooms are available today. As we have providers, many primary care providers who work 4 days a week, 4 10s, there's rotating rooms that are available throughout the clinic. And so we're not asking for our own exam room. We use whatever's available that day. We just ask for laptop, access to EHR, email, whatever form of communication is utilized the most, and Excel for tracking lists or whatever other system for tracking is available at your system. And then, of course, equipment for vitals, point of care testing, which most primary care clinics already have what we need. So I've mentioned this a couple of times. There are 3 different levels of psychiatric consultation that we utilize in this model of care, from highest to lowest intensity. So the highest level of intensity is what you would consider a traditional or conventional outpatient psychiatry appointment. We call it a comprehensive or a direct consultation, where it can be same day or it can be a future scheduled appointment, or it's a full intake. It's full scope, 60 minutes face to face with the psychiatric provider. That provider is taking over medication management. They are managing they're ordering labs, they're scheduling their follow-ups, with the goal of stabilizing them and their mental health symptoms to the point where they can return them back to primary care to continue on with maintenance management. If we go all the way down to the end, to the lower end of the intensity, that's the indirect interprofessional consultation. That's what we here just call indirect, or you could say it's formalized curbside consults. These are same-day consults as long as I'm in the office and not on PTO. And if I'm not immediately available, or if the primary care provider is like, I don't have time to go and run and ask them even the simple question, they send me a message in the patient's chart, and within 1 to 3 days, they're going to get a response. Again, depending on what the intensity is and if we're in-house, on-site, in clinic with them, or if we're out for the day. Most of the time, this takes as little as 2 minutes and up to 10 minutes with a provider, with a primary care provider. We really try to limit that. So again, we're not adding to the workload or adding to the time that the primary care providers need to spend in this. I find that most of the time it's 2 minutes and definitely under 5. And then I go back into the chart and do more of a chart review. I then go and write that recommendation in the chart. There are billing codes that we can submit for this. And depending on what state you're in, you may or may not be able to be reimbursed for that billing code for providing that for Medicaid patients at an FQHC. So that's something I'd encourage you to talk with your billing and revenue teams about. But again, this is no face-to-face time between the psychiatric provider and the patient. It saves time for everybody. They can get a quick answer to their question for those that are appropriate, and it's that lower level of intensity of questions. We then utilize this middle of the ground approach, which we are calling a problem-focused consultation. It is same day. It's the same time that they come in to see their primary care provider for the patient. It is a limited scope evaluation. I am not asking you every question under the sun. I'm not doing the full scope consultation. Most of the time, this takes me 15 to 30 minutes. It should still take just a few minutes of the primary care provider's time. I am face-to-face with the patient. I ask them specific questions. But at the end, I'm not taking over management. I'm still providing a recommendation to the primary care provider as a take it or leave it recommendation, and they retain management responsibility. And we're going to go through some examples of what that looks like later. So for a patient, as they come in to see their primary care provider here at Peak Vista, what does it look like for them to get in front of a psychiatry provider or get some sort of psychiatric intervention? So if we start at the top left, the patient comes in to see their primary care provider, and the primary care provider identifies that there is a mental health need. If appropriate, they're requesting a co-visit from their behavioral health provider, the non-prescriber who's on their team. And if needed, they can also then request a psychiatric consultation. As you can see, there is no gateway from the BHP to the psychiatric provider, and that's intentional. If the PCP or primary care provider requests that psychiatric consultation, there will be a discussion of the clinical question. What question do you want me to answer? Is this something that you feel like you can manage if I just answer your question, or does this feel like, well, it's way out of my wheelhouse and I want you to see them? That's usually how those discussions go. Then we determine together, the primary care provider and the psychiatric provider, on what is the intervention that's most appropriate. If it is an indirect or problem-focused consult, we provide the recommendations, the primary care provider manages the medications, and we remain available to be reconsulted at any time. If it is a direct or comprehensive consultation, I'm taking over management. I'm scheduling an appointment, or I'm seeing them same day. I'm taking over prescribing, labs, follow-ups, all of those things, with the goal of ultimately, again, stabilizing them, the patient, and the mental health symptoms to return them back to their primary care for ongoing management, which, again, our goal is that the primary care provider is just managing maintenance at that time. If we are unable to stabilize them, we need to refer them often to an external psychiatric clinic. That means that if within your system you do have a standalone psychiatry clinic, that is where we are sending them to, or an external community partner. For a very limited number of patients, they may stay in long-term care with this psychiatric provider. We have that caveat there of this being a very limited set of patients, because if we hold on to every patient who is unlikely to stabilize and return to primary care, the integrated psych provider schedule is going to get so full that then we don't have consultation time and we have only kicked the can down the road. I mentioned a tracking list or a registry. This is a part of this program that we adapted from the collaborative care model. So we have a HIPAA compliant database, and I would encourage you to confer with your compliance department on where you can best keep that, whether that's through a secure Excel spreadsheet that is kept internally and has the security measures in place, or if you have an ability to have a tracking list built into your EHR. There are also some resources that are available to be licensed to your organization, such as the University of Washington AIMS Center. I have no disclosure, I have no financial interest in their group, but we utilize this to track engagement in psychiatric care. So if a patient needs to see me for a comprehensive consultation where I'm taking over care, we are tracking them by their name and date of birth, who their primary care provider is, when was their first psychiatry appointment, when was their next scheduled appointment supposed to be, and any other notes that we need to track. This is updated daily by the provider and or the medical assistant that they are paired with. We do have an active panel list, a disengaged list, and then we also have a cancellation list or wait list for those who, if we have an opening, we can get them in right away. We are utilizing this tracking list to ensure that patients remain engaged in care by tracking their next scheduled date. If their next scheduled appointment is now a past date, so today is the 4th of August, if their next scheduled date was sometime in July, they are a patient that we are actively pursuing to try to get them back into care instead of just saying, oh, they missed their appointment. I hope that they call in the future. We use this then to increase the utilization of our schedule openings by using that cancellation list. So if someone has been calling and they do have a future scheduled appointment that is actually in the future, but now they're calling and they say, I'm having this problem. I need to see you sooner and I don't have an opening. If I do have someone that cancels same day, I can use this tracking list to fill our schedule real time. As an example, this is just some sample patients that I made up to show you what our tracking list looks like. So as you can see, each row is a unique patient. So John Doe up at the top, he sees primary care provider Smith. They referred them on the 30th of July, and look at that, we got them in the same day. That was also their most recent appointment, and I know that they're scheduled on August 28th. But Jane Johnson, they were referred on the 3rd of April. It took them 3 days to get that intake appointment. Most recently, I saw them on the 2nd of June, but they were supposed to have been seen on July 8th. They missed an appointment, and so now we have that as red. And so when we are going through finding openings in our schedule and wanting to utilize our resources to the best of our ability, we are actively pursuing this patient to try to get them back on the schedule so we can keep them engaged in care. And then you can see at the bottom that Bob Miller has an appointment on 8/20, and we use the notes to also track if they're due for a long-acting injectable antipsychotic, so we can make sure that that medication is delivered in time and ordered appropriately. Some notes at the bottom, you can see that primary care provider column. We use that to track engagement of primary care providers. If we see that most of the patients are from one provider and 0 are from another, well, then we need to readdress, are we accepting consultations from primary care provider Smith that are appropriate, or are we accepting too many where really we can help educate them and have them provide a lot of the frontline care to their patients? Or is there a primary care provider who's not listed there at all, who doesn't even know that we're available, and we need to educate them on the availability of our services? We also use the referral date and the initial date to track our wait times. Like I said, our goal is to never have more than 4 weeks of a wait time. And then again, that future date column is the primary driver of preventing patients falling through the cracks. So we're going to go through a couple of sample consultation scenarios just to show you what it may look like real time. So this is a sample for a direct or comprehensive consultation, which again is the highest complexity care. So for this example, a primary care patient has a chief complaint of this is a 50-year-old male who has chronic pain and depression. That was what they came to see their primary care provider about. The primary care provider went in and saw this patient and came out and said, hey, I need your help. They came in to talk about managing their arthritis and getting some referrals to some other specialties. But in the midst of this, during our screening, because we do regular PHQ-9 screening, they endorsed having frequent and ongoing suicidal ideation with a plan. And I'm really concerned and I'm not sure what to do. And maybe the behavioral health provider was busy that day with another patient. And actually, with all of this, the patient's wife got really upset and left. And so we don't know what's going on, but the patient is here and wants to see you. They're not on any meds. Can you come and talk with them? Because we have that protected consultation time, we don't have to schedule them out. I saw that man, same day. I was available real time. I was on site. I actually saw the patient in the same exam room. We didn't have to re-room them. Eventually, the wife came back into the appointment. During that consultation, I did a full intake review of psychiatric review systems, talked about diagnoses and management and future plans, scheduled a follow-up appointment. We did a risk assessment and identified that this suicidal ideation had a potential plan, but there was no intent, no desire to follow through on this. They were more intrusive thoughts that kept coming in their mind. We did some safety planning to make sure that their home was a safe environment, that they were safe to go home as opposed to needing hospitalization. We talked about having a family meeting that the patient and his wife could have with their family to talk about what's going on, why are these changes happening, how can we support this individual and our family. I provided a prescription as well as a referral for therapy and scheduled follow-up. At the follow-up appointment with psychiatry, which again was one of those scheduled appointments that I have in my day, they reported that their mood was improving with their family support. They remained adherent to their medications. Over time, they remained very engaged in care. We titrated or changed the dose of the medication. And after a few appointments, I think this one was like 4 or 5 appointments only, we stabilized them and returned them back to primary care to continue prescribing that antidepressant medication. The wife actually had stayed engaged by coming to the appointments with this patient, and at the end said, actually, I've been dealing with panic attacks and anxiety. Can I have an appointment with you too? So we go from this wife who left because she was so upset about having to even talk about this to then saying, oh my gosh, I think I need help. Can I have help? So from an overview of this kind of consultation, the psychiatry provider was on site, provided real-time consultation. There was no delay in care. It saved time for the primary care provider because they didn't know what to do. They're like, I have this patient reporting this concern. I wasn't trained in this. I've got 3 patients waiting for me right now. Help. And I was able to educate the primary care provider at the end of the day just to say, hey, thank you for consulting us. This is a perfect thing to do. This is what we ended up doing. Started this medication. I've got to follow up this time. And he's like, oh, maybe I could have done that. We saw the positive impact to the patient and the family. And then again, transferring back that patient to primary care reopened my availability to keep seeing new patients coming through too. So next we're going to talk about problem-focused consultation. So in this scenario, we have a 14-year-old male who has chronic motor tics and ADHD in attentive type. The primary care provider, which is a pediatrician in this case, said that this patient has been seeing neurology, who's been titrating guanfacine, which is a non-stimulant medication that we use for ADHD, but also to help with motor tics. But that medication wasn't working. Their tics were not getting any better. And this kid does have ADHD, and they wanted to talk about treatment for ADHD. The primary care provider came and spoke with me. We agreed that this is probably best for a problem-focused consult. I could provide education to the primary care provider, give them scripts and words to use to talk about risks and benefits, but that was going to take significantly more time. They only had one question. They had a question about what can we do about ADHD in the setting of tics and this medication that's not working. So they didn't need a full comprehensive consultation, but it was more time than just 2 minutes with a primary care provider. So while I was seeing a patient, my medical assistant brought in a questionnaire that we have created with some minimum need to know information. What meds are you on? What mental health diagnoses have you had before? Family history, cardiac history, a few things that might impact our prescribing, and gave them a paper with a consent form that outlines what a problem-focused consult is. They were given a chance to read through that so that when I came into the room, they had read through it and they could ask any questions. Effectively, this problem-focused consent form identifies that I'm coming in to see you. I'm not going to ask you every question possible. That means that I can be missing very important things that could impact the outcome of the recommendations I give. But the benefit is that I can provide you with this recommendation today without having to delay care further. For this outcome, or for this consultation, I ended up spending about 15 minutes in the exam room with the patient and the patient's parent. We discussed the risks and benefits, side effects, alternatives with ADHD treatment, including the impact of different medications on tics. We collaboratively agreed to continue or to recommend that the primary care provider continue guanfacine as the neurologist had started, but also to initiate a stimulant, methylphenidate XR, to treat their ADHD symptoms while also monitoring tics. In this specific case, they were concerned that the stimulant could worsen or cause tics to be worse. And so we talked about the risks and the frequency of that happening. We said it actually doesn't, it may exacerbate tics, but it's not going to cause them. And the guanfacine has not been helpful. These ADHD symptoms have been so negatively impactful. We recommend starting a stimulant and monitor the tics. They don't get worse for everybody. The primary care provider was comfortable with that. They sent in the prescription and they continued management and kept me informed with how things were going. I was available for consultation later in the future too. This kind of consultation was only possible because this patient only had a single straightforward question: what can we do for ADHD in the setting of these other medical complexities? It didn't require full intake. I was available real time on site, didn't have to send them to another place or send in a referral. And my medical assistant facilitated the workflow. There was no interruption to the primary care provider's workflow. There was no interruption to my workflow. In fact, a bulk of that work that happened beforehand was as I was finishing another appointment. It took about 10 to 15 minutes of discussion between myself and the patient's guardian. How is this better than a referral for a direct consult? Again, there was no delay in psychiatric expertise being provided to the patient. My schedule remained open to see more complex patients. And the primary care provider was able to learn, what can I do next time? What did Dr. Ash say that now I can try to utilize too, or I can read up on? And they were not left floundering without knowing what to do until the referral could be picked up and the patient could be seen. All right. And finally, the indirect interprofessional consultation example. So a primary care provider came to me and said, I've got this 30-year-old female. She's got really high anxiety and she's having panic attacks as well. She's been prescribed bupropion XL 300 milligrams for years for depression. We've never thought about changing that. The patient said it was okay if I consult with you. What do you think we should do? They consulted with me. We literally worked side by side, or we're elbow to elbow in the workspace, which is a really important part of this model, not being co-located and in a separate workroom. And I was able to provide immediate verbal recommendations to the primary care provider. I said, the bupropion XL, it's really helpful for depression, but sometimes it can worsen anxiety. Some people can have a higher anxiety experience when they're on that medication. So that's something we need to consider. Should we stay on that or taper off of that? Also, SSRIs, or selective serotonin reuptake inhibitors like sertraline, are actually really helpful for anxiety and panic and depression. And that might be a better medication to utilize if we need a medication to kill three birds with one stone. And also, I think this person should be in therapy if they're not already in therapy. Can we get our behavioral health provider involved? So we talked through a plan of timeline and how could we implement these things, what were the highest risk or higher priority tasks that we needed to discuss with the patient. And the primary care provider went right back into the examiner and said, hey, I just talked with Dr. Ash. This is what I think we should do. What do you think? Let's get rolling with it. This was possible because the primary care provider was comfortable managing psychiatric medications with support. There was real-time on-site availability of psychiatric provider. Notice the theme here. And there was an immediate response to the request. They didn't have to wait 2 or 3 days for me to get back to them. Sometimes we do if I'm not on site, if I'm on a PTO, or if the PCP doesn't have time to discuss with me right then and there, but there's availability for an immediate response. Again, this took 2 to 3 minutes for me to discuss with the primary care provider. And it took about 5 to 10 additional minutes on my own afterwards, later in that day, to document my recommendations, to have in the patient's chart. So whether it was this primary care provider or another one in the future that helps them, they can go back and rely on that documented recommendation. This is better than a direct referral because, again, there was no delay in expertise. My schedule, again, remained open for more complex patients. The primary care provider had no meaningful disruption. The amount of time it took them to talk with me was probably about the same amount of time that they would have taken to have to write a good referral request. Their competence and comfort increased in managing psychiatric medications. And they had improved therapeutic rapport with the patient because now they were able to support the patient instead of saying, sorry, I can't help you, go see that person over there. So they're building more of that alliance with the patient. All right, so let's talk about the impact of this programming so far. So at a recent sampling, my medical assistant and I did some manual data tracking while I was on-site and off-site. So as I started this program, I was splitting my time roughly 50-50 between 2 clinics so that I could support 2 clinics at the same time. But that meant that there was some time where I was consulted with on-site and some time where I was available through Microsoft Teams and the chart and phone, but I was off-site instead. And so we used this opportunity to gather data on what does the impact of being on-site look like. We found that there was a higher utilization of true curbside consults, meaning they didn't even ask me about a specific patient. They're just walking to their examiner and like, hey, what's the starting dose for this med again? So there's a higher utilization of those kinds of supports and all formal consult types when I was on-site compared to when I was off-site. In fact, there was almost double the amount of curbside consults and educational interactions with primary care providers when I was on-site compared to being off-site. At the same time, over 4 weeks, combining both the on-site and off-site data, but only accounting for 1 clinic, I still had 167 scheduled appointments. There were 83 curbside supports or educational interactions, which is what we would call it, what we generally call a curbside consult. There were 17 formal indirect consults, which is that formalized curbside consult. We only had one problem focused consult. My medical assistant spent greater than 20 hours in care coordination, meaning they were using the tracking list to make sure patients were staying engaged in care, that we were getting medications sent in and ordered and delivered on time, that they were helping me with sending communication back to the patients and scheduling as well. In the midst of all of this, I spent probably 4 hours, almost 4 hours, providing or preparing educational materials for the primary care providers. Like I said, we provide handouts, one-pagers, cheat sheets, really, for primary care providers in managing psychiatric concerns in their practice. And at the same time, during this time, I spent time precepting 6 different multidisciplinary learners. So a medical student, psychiatric nurse practitioner fellows, and a psychologist who is getting their prescriber's license. So we did all of this together, all with one person and one prescriber and one medical assistant, able to impact all these different patients and providers and really amplify the impact that we could have. Those educational impacts really are the lion's share of the amplification of impact for this model. If we can improve the knowledge base and comfort of primary care providers in managing psychiatric meds, they can help more patients just by sheer number. I don't remember the citation, but there was some report in the back that I had an attending tell me that just by sheer volume, primary care providers are going to manage more psychiatric concerns than psychiatry ever could because of the number of appointments they have every day. And then again, this preserves the availability within psychiatry to see the more severe cases. Those curbside supports and educational opportunities like, hey, Dr. Ash, what do you think about this medication? How do I dose this medicine again? They're having side effects. That's usually not reimbursable or billable time, but it is a high value added service for our patients, our providers, and our system. And I recognize that takes a system that recognizes that value and is able to invest into that system too, which requires a certain size of a system to do that. Those reference sheets, like I talked about, they're quick, easy references that are easily utilized. It is taking a textbook and putting it into one page. We've created some handouts like pediatric and adult ADHD management, first steps in depression and anxiety management, mood stabilizer dosing and monitoring, insomnia management. These are just a few examples. Some ideas that are in progress or reference sheets that we're creating are how do we manage reports of suicidal ideation? Even after we've included our behavioral health provider and done safety screening and risk assessments. And also, how do we prescribe medications in the perinatal period too? Got some quotes from the primary care providers that we work with. One said, I wouldn't be able to manage half of what I do now if you weren't here. Seriously, if these patients would probably just have to go without until they could get in, if they could get in somewhere else. Another newer primary care provider said, I told my old classmates that we have a psychiatrist in-house and they couldn't believe it. We're so lucky to have support here. I've learned so much. From patients, they've said, this has been great. I don't have to figure out where to go and who to go for what. You and my primary care provider can talk directly and figure out what needs to be done. So it takes them from being a middleman to not having to do that and depend on face-to-face contact between me and the primary care provider. Another saying, I can't believe I was able to be seen today. This is incredible. I'm so glad we could be seen here. I really didn't want to have to go somewhere else. And so if you think of these patients and what they're saying, there's a lot of potential barriers to, even if you do have a good external referral location that you can send someone to, are they going to be able to show up? Are they going to have the ability to overcome that stigma and the concerns that they have? Are they going to want to deal with yet another system of care to try to get what they need? And some additional unique population benefits. Like I mentioned before, some of the other models of integration, like the collaborative care model, sometimes will limit the patients who can participate by the diagnoses that they have, and we do not have that limitation here. Even those with severe or serious mental illness can participate in this program. So we have patients who have schizophrenia, who have bipolar disorder. It's not just for depression, anxiety, and ADHD. We are able to increase the coordination of care between psychiatry and primary care, especially for those with severe mental illness. they oftentimes will go without primary care because they're trying to get in to get their mental health taken care of. And we know that the medications that we prescribe have a significant impact on their physical health too. And so it's so helpful for us to have primary care, not just for us for primary care to have psychiatry available, but honestly for psychiatry to have primary care available too. Um, this does increase, again, real-time availability psychiatry. And in fact, we've been having patients and families hearing about and seeking out Peak Vista because of this program and being able to see everything in everyone in one place. Some of the lessons learned as we've been rolling out this program is one potential issue is overbooking. So like I said, if we schedule patients into that consultation time, that does significantly reduce our availability for consultation. So that means that leads to less learning for primary care providers when the psychiatry provider takes over as well. So our goal is to really adhere to scheduling, to reduce scheduling and keep that in the scheduled appointment times so that we can remain more available for same-day consultations. That does not mean that we don't see patients during that consultation time. We absolutely do, but those are the same day consults. We keep our scheduled appointments in our scheduled appointment time, and that available consultation time makes sure that we're available for the patients and providers when they need it. We've also learned that it is really important to prepare a clinical site prior to embedding a psychiatric provider there. We had a very challenging uptake of the model in one of our clinics that was not sufficiently prepared. We have since overcome that, but that took a lot of time. Instead of going ahead and having lots of meetings, joining their unit meetings and their provider meetings and familiarizing them with the program and the workflows and how do you reach out to us, if we would have done all of that beforehand, we could have had a faster uptake of consultation utilization at that clinic. Again, it's not something that's insurmountable, but it would have made it a lot more successful from the start. And we are still learning and determining appropriate ratios, meaning how many psychiatry providers, integrated psych providers, do we need at every primary care clinic? Do we need one in every primary care clinic? Should we base that on the number of patients that are impaneled there for primary care? Should we base that on the complexity of patients and the complexity of their mental health diagnoses? Should we base that on the experience of the primary care providers and their comfort in managing psychiatric medications? And we don't have clear answers on that, and I haven't been able to find any. If any of you do know, please share that. I would be more than happy to hear that. And our goal is to determine an efficient and highly effective staffing ratio to optimize the impact of each of our psychiatric providers. So for future growth, we do have hiring in process. Some of the clinics that we are going to be expanding into our women's health center here at Peak Vista, our pediatric clinic, and we have multiple other family medicine clinics, lifespan clinics, including our outlying rural clinics, trying to identify how can we best support them. Even if they can't support one full-time provider, can we have someone who does partial on-site and partial virtual support for them, knowing that the virtual support likely is going to lead to less utilization, but having a regular physical presence may help build those relationships too. As we are doing this hiring, I'm having a program rollout tour where I go to another clinic, teach the primary care providers and the operations teams how this program works, so that when we do hire someone full-time, that team is locked and loaded and ready to go. And then some more educational opportunities. We're always producing more reference sheets for our primary care providers and updating those sheets as new information comes out. We recently did a large group presentation covering or supporting the primary care providers of 9 of our clinics. So for those that did not, that are at a clinic without an integrated psych provider already, we actually took all of the reference sheets that we have made, put them in a single binder, and gave a 1-hour presentation to all of them and did rapid fire. Here's the information that can support you, and here's a 1/2-inch binder that you can keep on your desk and pull it out quickly if you need support. Oftentimes people like to have that from someone that they have a relationship with, professional relationship, or they like, I know Dr. Ash, this is what he recommends, as opposed to looking up things on Dr. Google and not being sure is this reliable or not. And then we've been having monthly presentations at the Women's Health Center to support those primary care providers, women's health providers there as well. All right. Well, thank you so much for giving me a chance to present with you guys today. This is my email here at Peak Vista. If you have any questions or concerns, please don't hesitate to reach out. I'm more than happy to share resources. Like I said, one of our goals is that this is a sustainable model that can be reproduced in other places. And I know that if you ask 10 different integrated psychiatry teams what it looks like, you're going to get 11 different answers. And that's even true even within our own system of care here. And so there's not one size fits all. We want it to be modeled to the needs of the patients and the primary care providers of that clinic, even within the same system. But I'm more than happy to support in whatever way we can.
Great. Thank you so much, Dr. Ash. That was really great presentation. And we have about 9 minutes left in the session today. So I wanted to open up to the audience to see if they had any questions while we have Dr. Ash on. Feel free to come off mute, or if you want to put some questions in the chat, I can read them out loud as well. While people are thinking of the questions, oh, Carrie, do you want to?
I do have a question. Thanks, Dr. Ash. I thought this was a great presentation. I work for a clinic of family health and wellness, and we do have integrated psychiatry, but what we don't have is a medical assistant who works with the psychiatrist. And I just wanted to comment. I think that's amazing because it sounds like that person can do a lot of the tracking and like outreach, like if they miss an appointment, to get them back into care. So I will be sharing that nugget of wisdom to see if that's possible for us.
Yeah, I think that was crucial to us setting up a successful program. I had a frank discussion with my boss and said, if I don't have a medical assistant, you'll be paying me to be a very highly paid secretary for myself and medical assistant of my own. And that is not a good use of resources. You want me seeing patients and working at the top of my license. And so let's facilitate that for myself and the others on my team. And we've been able to keep a high utilization, a high show rate. We have a very low no-show rate for our psychiatry providers. And we have a high utilization rate, meaning even if we do have a no-show, we have that tracking list to get patients in to utilize those openings in the schedule. Psychiatry has longer appointment times. We inevitably have fewer appointments than other specialties, especially in community health centers. And so we need to be proactive. We need to be actively managing our patients, not passively waiting to see who shows up. That's part of what makes this a sustainable model.
Thank you.
All right, we did have one question in the chat as well from Lander. They said, I agree there's a lot of value in the non-billable components of this model, including consults, education, etc. That being said, what is the target mix of billable visits for providers?
That's a really good question. Our goal is to make this program a self-sustaining program. So you have to work with your finance team to see what kind of overhead you have to support, what the salaries are, the providers that you're working with, and how many and what your reimbursement is for those appointments, and try to figure out what's that number of appointments that you need to have. It is going to be different at every clinic and at every system. We are not a big profit center for our clinic system, but we are a big value added program for our system. And so our goal has been to keep ourselves self-sustaining without having to depend on other programs to facilitate our funding. So that really has to come down to what your salaries are and overhead and reimbursement expenses. Some models function on a 60-40 model, meaning we have 60% of your time is scheduled appointments and 40% of your time is consultation time that's protected. And for most psychiatry providers, that means that those are 60-minute intake appointments and 30-minute follow-up appointments. That's actually a fairly tight scheduling, and that's in most other psychiatry places that I have practiced in and trained in. Even for like child psychiatry, it's a 90-minute intake, but we don't have that here. So we have 60 and 30-minute appointments. And then there are other models that have 80-20. So 80% of your time is scheduled consult time, or is scheduled appointments, and 20% is consult time. And I want to be very clear that consultation time is not admin time. It is not time to do your notes and catch up on your in-basket. It is time to be available for primary care providers to come and talk with you. You can still use that time to do other things if you're not being consulted, but that is time to be used to support our primary care providers and their patients.
Great, thank you. Wanted to open up to see if anyone else had any last minute questions. We got 5 minutes left. All right, well, I'd like to thank Dr. Ash again for sharing their expertise with us today, and thank you to all for joining today's session. As always, your opinions about today's event are really important to us and our federal funders, so if you could please take a short minute to complete the set of evaluation questions that are linked in the chat, that'd be really great. I'll also be sending a follow-up email with a link to the recording of the session, so if there are any folks who weren't able to join today's live event, they can view the recording as well. And I wanted to share about our last session, which will be next month on Tuesday, September 1st. At the same time, we'll be having folks from Valley-wide health systems. They'll be sharing about the Coffee Break Project, which is a community partnership that is intended to provide mental health education, support, and assistance in the rural ranching and agricultural community. We hope to see you all there for that last session. And once again, thanks all for attending, and I hope you guys have a great rest of your week.
Thank you.
Thanks, everyone.